Occipital condylar fractures occur as a result of high energy trauma. They can be seen in the craniocervical fractures and injuries. In this video, we will discuss the mechanism of injury, the classification, and the management. I am Mohammed Raz, and this is your knowledge platform about the brain, spine, and beyond. As I said, the condylar fractures result from high energy injuries. You can consider it as a type of a skull-base fracture. It has been reported in about 4% of traumatic brain injuries and usually seen in the context of motor vehicle accidents. Patients will have neck pain and reduction in the range of movement in the neck. But given it's likely to be part of a high-speed injury, patients might have a low GCS because of the traumatic brain injury. And if the injury is so severe, that can cause disruption of the craniocervical junction, and the patient might have a neurological deficit in the lower cranial nerves or some sort of limb weakness. Before we jump into the classification, let's see where is exactly the occipital condyle and its relationship with the surrounding structures, because it's essential in understanding the classification and the management. The occipital condyle, as you can see, forms part of the occipital condyle in the cranium. They are kidney-shaped, as you can see in this picture, and they form on the underside of the occipital bone. The anterior extremities of the occipital condyle are directed forward and medially. The anterior parts are closer together than the posterior counterparts of the occipital condyle. The posterior extremities of the condyle extend backward to the middle level of the foramen magnum, as you can see. The articular surface of the condyle slopes downward and laterally near the base of each condyle. There is a short tunnel which is called the hypoglossal canal, which contains the hypoglossal nerve, as you know. These condyles importantly articulate with the first cervical vertebrae, C1, and which is known as the atlas. They form a capsule of the atlanto-occipital joint, attaches to the margins of the condyle. These capsules are really crucial in the stability of the joint. On the medial side of each condyle, there is a rough impression of the tuberculum where you have the attachment of the alar ligament, as you can see here, which is this one in blue. I will make another dedicated video for the craniocervical junction anatomy and the ligamentous structure supporting it. So now, as we understand and we know the anatomical landmarks of the occipital condyle, so that we would know what would happen if this, or what would be at risk of this if these occipital condyles are injured. This would be the atlanto-occipital junction, the hypoglossal nerve, the ligaments, and definitely the spinal cord or the brainstem. In terms of classification of the cervical occipital condylar fractures, there are two classification systems. One is more descriptive and one is more clinically oriented. The first one is the Anderson and Montesano, which relies more on the morphology of the fracture, as you can see here. The fracture, if it's in place, that will be type 1. If the fracture extends into the skull base, that would be type 2 fracture. And if it's displaced out of its place, then that would be a type 3 fracture. As I said, this one is more descriptive and it doesn't have much of clinical practicality or clinical value. Anderson and Montesano described this in 1976 article, which described 6 cases of condylar fractures. As you can see in this picture, that was diagnosed on X-ray, which looks very low quality. The other classification system is Thule classification, which this classification, they added the point of the occipito-atlanto-axial instability to the equation, making that more clinically oriented. Type 1 of that fracture is pretty much the same as Montesano classification, where the condylar fracture is undisplaced. Type 2 is displaced one, but this is divided into either A or B, which makes it either stable or unstable. And this relies on some criteria to assess the stability based on the CT imaging findings. As you can see here, I will leave this for you to review it. In terms of imaging of the occipital condylar fractures, it's mainly done through the CT scan, which is part of the trauma survey. But the MRI also can be used, which will help to assess the ligamentous injury, the soft tissue injury, and any brainstem or cord injury. Most of the condylar fractures are very likely to be treated conservatively with a collar. Surgery can only be done if there is an associated atlanto-occipital instability, which might require fixation. Finally, let's have a look on some of the CT scans and see how can we identify the condylar fractures on the CT. So as you can see here, this is an axial image of the brain. This is the bone window. You can see there is some soft tissue swelling here, and that means that this patient had some sort of fracture. Also, you can see some hypodensity, which is basically representing air, which means again some air around this area. If we want to see the occipital condylar fracture, then if we go all the way down, this is basically the occipital condyle on each side, and if we move, then you will find this is the arch of C1, and this is, they can see here there's a line of fracture on the left side of the occipital condyle. Again, you can have a look on the coronal view, and if we go, as you can see here, this is the occipital condyle, this is the C1, this is the odontoid C2 peg, and you can see again there is a line of fracture here through the occipital condyle on the left side. And if we move towards the sagittal imaging, then if we go from one side to one side, this is the clivus, and if we move to one side here, you will find again this towards the occipital condyle, and again there is a line of fracture, as you can see. I hope you enjoyed this video. Stay tuned for the next video where we'll go through the atlanto-occipital dislocation. Please let me know in the comments below if you like the video structure and how you want to make it better. See you.